Hello everyone, and welcome to the lesson on respiratory tract infections. In this lesson, we will discuss different types of respiratory tract infections. To introduce you to this lesson, I presented you with a sample from the patient Kani-san. After reading the case history, consider the points I listed here as you proceed with your assigned readings. In this lesson, you will encounter additional cases that will hopefully guide you to determine the sources of respiratory tract infections and the potential pathogens that cause these infections. Within the lecture's upper and lower respiratory tract infections, we will discuss general concepts of infectious diseases of the respiratory tract, including the role of normal microbial flora in preventing infection and the importance of the host immune status in determining the pathogens likely to cause the disease. I divided this lecture in two parts. In the first, we will talk about the infectious diseases and what caused them, and then in part two, we will review how they are identified in the laboratory. The learning objectives for this lesson include list the usual inhabitants of the upper respiratory tract, determine how each pathogen establishes the infection, associate the predisposing factors that lead to respiratory infections in different population groups, describe how respiratory infections are transmitted and acquired, describe how the following commonly recognized upper respiratory infections are established and present the appropriate therapy. This includes pharyngitis and tonsillitis, epiglottitis, thrush, diphtheria, whooping cough, and Vincent's angina. Be able to associate the etiologic agent with each infection. For each of the following organisms, Group A beta hemolytic streptococcus, Bordetella pertussis, Haemophilus influenzae, and Corynebacterium diphtheriae, determine the appropriate specimen, method of collection, and major isolation media for maximum recovery. Describe the colonial appearance of each organism and decide on the process of identification using key tests and biochemical reactions. So here's a case study on Connie-san. You received a throat swab and a nasopharyngeal sample taken from a 7-year-old child, Connie-san, for microbiological examination. Connie presented with complaints of swollen, painful lymph nodes on her neck. She complained of sore throat, muscle ache, headache, and fever. The onset of the symptoms were abrupt. She was feeling well the previous 24 hours. So after reading that case introduction, what clues indicate the type of infection present? What organisms or organism would be considered in this type of clinical presentation? How are these organisms transmitted? And what types of complications may develop as a consequence? Respiratory tract infections account for the vast majority of what we call sick calls. Because prognosis varies from benign, self-limited illness to potentially catastrophic medical emergencies, the ability to distinguish among the various clinical syndromes is extremely important to the clinician. As a clinical microbiologist, it is therefore imperative that you are able to provide the clinician the most valuable information at the time that the clinician needs to make a clinical decision. But let's first start reviewing the anatomy of the respiratory tract. Infections of the respiratory tract fall into two broad categories: Upper respiratory tract includes the nose, the nasopharynx, the pharynx, larynx, and epiglottis, while the lower respiratory tract includes the trachea, bronchi, and the pulmonary tissues. Before we begin, let us review the list of organisms that comprise the respiratory tract, certainly recognizing that the upper respiratory tract is colonized by the usual inhabitants such as alpha hemolytic streptococci, non-hemolytic streptococci, Neisseria species, and others, as you can see in the first column in this table. You also see in this table that there are organisms that are seldom associated with respiratory tract infections, while others may colonize a healthy individual without causing any clinical infection or symptoms. However, given the opportunity to establish disease, these potentially pathogenic species, the organisms listed in the middle column, we call opportunists, are capable of extending or complicating an original infection or cause a primary infection. Occasionally, the infection may be ascribed to true pathogens, and that is the last column on the right. Those species are listed here. Unlike opportunists, true pathogens cause infections in healthy individuals without any compromising risk factors. The respiratory tract has many natural barriers to infection that inhaled organisms must penetrate before they can cause disease. Among the elements of the respiratory tract and its functions that help prevent infection are physical barriers, such as the nasal hair, mucociliary cells that line mucosal surfaces, coughing, and sneezing. Other barriers are the normal biota or normal flora, secretory immunoglobulins, defensins, and phagocytic inflammatory cells. Alterations in these barriers may lead to infection or increase the risk of infection in susceptible individuals. So let's take a look at the organism-host interaction. So first, let us review the organism's virulence factors. First are specific adherence factors. We know that microorganisms possess structures for adherence. For example, the cell wall of group A streptococci contain lipoteichoic acids, as well as M proteins on its pili or fimbriae. Bordetella pertussis has proteinaceous structures for adherence as well. Other virulence factors associated with certain organisms are the production of extracellular toxins. For example, again, Bordetella pertussis produce toxins that inhibit phagocytosis. We know that Corynebacterium diphtheriae produces toxins that cause necrosis of tissues. Colonization is another virulence factor of organisms. Just by virtue of its presence and growth in the host tissues, normal tissue function is altered. Its presence also attracts host immune factors such as macrophages and neutrophils. Organisms also have the ability to evade host defense. Streptococcus pneumoniae and Haemophilus influenzae possess capsules that enable them to evade phagocytosis, while others, such as chlamydia and viruses, prefer to invade and multiply within the host tissue cells. Another perfect example for an organism that can survive intracellularly is Mycobacterium tuberculosis. So if organisms have virulence factors, we have our immune defenses. So what are they? The normal flora of the nasopharynx and oropharynx help protect us by preventing colonization by pathogenic organisms. The normal flora can prevent proliferation and invasion of pathogenic organisms through competition for the same nutrients and the same receptor sites on host cells. So you have to be familiar with the normal flora of respiratory tract because it is important in determining the clinical relevance of organisms recovered in culture. For example, isolation of alpha hemolytic colonies from a pharyngeal culture from a patient with pharyngitis carries little significance because alpha hemolytic streptococci are normal biota in the oropharynx, whereas recovery of alpha hemolytic colonies in properly collected sputum samples requires complete identification. So let's go back to our host immune defense. For any organism to cause disease, it must first enter the respiratory tract. And there are several mechanisms that serve to non-specifically protect the respiratory tract from infection, namely hair, mucus, and epithelial cells that line the respiratory tract. The convoluted passages, secretory antibacterial substances, and reflexes such as coughing, sneezing, and swallowing are our mechanical defenses. Nasal hairs filter air as it passes through the nasal passages. So humidification of the air causes hygroscopic particles to increase in size, making it more likely for them to be cleared by mechanical mechanisms of the upper respiratory tract, such as sneezing or coughing, that aid in the clearance and expulsion of particulate matter. The mucociliary blanket of the sinuses, middle ear, and tracheobronchial tree clears particulate matter. They also secrete immunoglobulins and other microbacterial substances. So for example, when you go out in the cold, why does your nose start running? It is a response to the cold temperature. On the other hand, cigarette smoking impairs the ability of the ciliated respiratory epithelium to clear particulate matter and interferes with phagocytic cell activity. Hence, smokers are more susceptible to respiratory tract infections. If particles reach the alveoli in spite of these mechanical defenses, resident macrophages ingest organisms. Polymorphonuclear leukocytes and monocytes are recruited once the lung becomes inflamed. Decrease in both numbers and efficient functions of these cells place the host in a compromised situation. We already know that infection is very common in individuals with decreased WBCs. Even when adequate numbers are present, inadequate function or migration predisposes them to respiratory tract infections. Did you know that when you get drunk, migration of WBCs slow down, so they must get drunk as well? High blood alcohol has been shown to slow down the migration of WBCs, hence a risk factor among alcoholics. As laboratory professionals, we must consider the virulence of the organism and the defenses available to the host to counteract establishment and progression of infection when we try to determine if a microorganism isolated have caused infection or is causing infection in a given host. So considering the host defense mechanisms, there remain various risk factors that predispose us to respiratory tract infections. So for example, season of the year, you will find that there is greater incidence as well as severity of infections during the colder months, that is from fall to spring. Certain types of respiratory tract infections have a peak seasonal incidence and may occur in epidemics in the community. Cases of group A infections and viral respiratory tract infections, for example, are more common in winter months, between November and February, while Mycoplasma pneumoniae typically occur throughout the year without any marked seasonal variability. Another is exposure to cold. And this is where even my own daughter does not believe me, because I see her not dressing the girls, my granddaughters, warm enough, especially during the winter time. There is evidence that chilling and long exposure to cold after prolonged warmth predisposes you to respiratory infections. Exposure to cold has often been associated with increased incidence and severity of respiratory tract infections, so it is not all wives' tale like my daughter believes. The data available also suggests the longer duration of exposure, the higher risk of infection. Although not all studies agree, most of the available evidence from laboratory and clinical studies suggests that inhaled cold air, cooling of the body surface, and cold stress induced by lowering the core body temperature cause pathophysiological responses such as vasoconstriction in the respiratory tract mucosa and suppression of immune responses, which are responsible for increased susceptibility to infections. Malnutrition and improper diet are also factors that increase risk for respiratory tract infections. Most respiratory diseases, such as pertussis, tuberculosis, even group A streptococci infections, occur more frequently among those in lower socioeconomic households. Lower body resistance. Those with chronic debilitating illnesses, those who suffered from previous illnesses are predisposed to these types of infections. In addition, age is also a risk factor, as we already know, the very young and the very old. Why? Because of immune deficiency in this particular population. Chronic infection of the respiratory system, cold and viral infections, allergens, emphysema, and other chronic disease of the respiratory tract make individuals more susceptible to this type of infection. Repeated trauma of the mucosa, such as those brought upon by chemical, that is, drugs and alcohol, physical, such as smoking, and other allergens predispose individuals to respiratory tract infections. Reduced clearance of secretions brought upon by reduction in function of the mucociliary mechanism. Chemical agents and other substances, such as those from smoking, as I mentioned previously, traumatize the mucous membranes. Or reduction in viscosity of the mucus, such as in cases of cystic fibrotic patients. Lastly and briefly, upper respiratory tract infections are usually acquired through droplet or aerosol spray, that is when someone coughs or sneezes, or by direct contact of mucus or respiratory secretions from an infected individual. Lower respiratory tract infections are acquired by inhaling organisms into the pulmonary parenchyma, or when organisms are aspirated and not expelled. Seeding of the lung tissues may occur in cases of bacteremia. So in essence, understanding the concepts and principles of the organism-host interaction is really important for us in assessing and evaluating cultures to determine respiratory tract infections. So now let's review the most commonly recognized respiratory tract syndromes and their respective etiologic agents. Let's start with pharyngitis, tonsillitis. Most pharyngitis cases in all age groups are caused by viruses including rhinovirus, coronavirus, adenovirus, parainfluenza virus, Epstein-Barr virus or EBV, and influenza. But the most common cause of acute bacterial pharyngitis and tonsillitis is group A hemolytic streptococcus or Streptococcus pyogenes. Group A streptococci and other pathogens are usually acquired by contamination of the hands and then inoculation of the upper respiratory tract or by inhalation of droplet aerosols. The frequency of the infection is related to age and time of the year. The carrier rate among children between 5 to 10 years old is about 5 to 25%, and with 25% rate of incidence. Carrier rate in children from 6 to 15 years old is about 40 to 50%, and the frequency is higher in cooler months. Respiratory infections due to this organism occur more often from September to March, while impetigo, the skin infection, is higher in the summertime. In streptococcal pharyngitis, the onset is abrupt. The patient presents with severe headache and fever, muscle ache, and a sore throat. Exudative material at the back of the throat, as you can see in this particular image, may be evident, and the uvula is beefy red. These are the hallmarks for a bacterial or streptococcal infection. So here you can notice the beefy red appearance at the back of the throat and the exudates along the side. Cervical lymph nodes are swollen and tender. It must be noted, however, that other agents may provide similar clinical manifestations. Remember scarlet fever. It is a pyodermal manifestation that may accompany a streptococcal respiratory infection. This syndrome is produced by certain strains that produce an erythrogenic toxin. As we have previously learned, untreated repeated cases of streptococcal pharyngitis may result in non-suppurative complications or sequelae, such as acute rheumatic fever. Rheumatic fever may occur about 3 weeks of post-pharyngeal infection. There is inflammation of the connective tissues and joints, heart, and brain. High fever is present, and the most serious form is carditis and the resulting valvular damage. Acute glomerulonephritis may result as a postcutaneous or pharyngeal infection that occurs about 10 to 21 days between onset of infection and development of nephritis. The patient shows signs of edema, hypertension, hematuria, proteinuria, and the presence of gas in the patient's urine. As we have previously learned, there are numerous extracellular toxins and enzymes produced by group A streptococci that contribute to its virulence. Review the role of these enzymes and toxins in the pathogenesis of streptococcal infections. Penicillin remains the choice of antimicrobial therapy, and for those who show hypersensitivity to penicillin, erythromycin is an alternative choice. Although Streptococcus pyogenes is the primary cause of acute bacterial pharyngitis, cases of pharyngitis may also be caused by unusual bacterial pathogens, such as Neisseria gonorrhea, particularly in the homosexual population, and other beta hemolytic streptococci, and Archaeobacterium hemolyticum, a gram-positive non-spore-forming rod that produces beta hemolytic colonies morphologically similar to group A streptococci. Hence, it is crucial that proper laboratory diagnosis is made. Non-bacterial agents include viruses and Mycoplasma pneumoniae. Mycoplasma pneumoniae causes pharyngitis, particularly among teenagers and young adults throughout the year. Parainfluenza and influenza, respiratory syncytial viruses, or RSV, cause respiratory illnesses with pharyngitis. EBV is a major cause of pharyngitis among college-age students that may mimic streptococcal pharyngitis. In the military, adenoviruses is a major cause of pharyngitis. Now let's talk about pertussis, the 100-day cough. An 18-month-old female infant was taken to a rural hospital emergency room with fever, vomiting, and productive cough of 2 days duration. The baby refused to eat after the coughing episodes, which were also followed by vomiting. Initial respiratory manifestations began with a cold-like presentation with just sneezing and coughing. Then the child's illness progressed into a paroxysmal cough. Medical records show that the child had missed the last scheduled immunization for childhood diseases. The laboratory report showed an increased white blood cell count with marked lymphocytosis. The physician requested for a nasopharyngeal culture for Bordetella pertussis. Pertussis, or whooping cough, is a highly communicable respiratory disease that traditionally occurs in infants and young children, although during recent years the incidence in young adults has also increased. Humans are the only source of infection, and transmission is by inhaling droplets. In the case presented, the physician suspected pertussis immediately because the child presented with several clues typical of this disease. These are the hallmarks: paroxysmal cough with whoop, an elevated white blood cell count, and marked lymphocytosis. The illness lasts for several weeks. Hence, the Chinese named this acute respiratory illness the 100-day cough because of its prolonged course. Symptoms appear about 5 to 10 days after exposure. There is a prodromal stage where the infection is most communicable. The patient presents with respiratory symptoms of fever, mild cough, and runny nose. Then the disease progresses to a paroxysmal stage with coughing, which is the hallmark of the disease. An inspiratory cough that ends up with a whooping sound when the child gasps for air. Then vomiting and anoxia follow. We have known that pertussis is primarily a toxin-mediated disease. The bacteria attach to the cilia of the respiratory epithelial cells, produce toxins that paralyze the cilia, and cause inflammation of the respiratory tract that then interferes with the clearing of pulmonary secretions. The excessive coughing followed by vomiting and anoxia is the result of this organism's attachment to the ciliated cells lining the respiratory tract, where they grow and multiply. The ciliated cells lose the cilia that results in the excessive production of mucus. The organism also produces a toxin that promotes the destruction of the ciliated cells. Lastly, the organism produces a lymphocyte promoting factor, or LPF, giving the appearance of a viral infection. If you have learned this from hematology, that lymphocytosis usually indicate a viral infection. Until recently, however, it was thought that Bordetella pertussis did not invade the tissues. However, recent studies have suggested that the bacteria also are present in alveolar macrophages. Treatment for pertussis consists of erythromycin and corticosteroids. This shows a schematic diagram of the clinical manifestations and the course of the pertussis disease, showing the three stages: the catarrhal stage, the paroxysmal stage, and the convalescent stage. What you're seeing in this image is a right Giemsa-stained bronchoalveolar lavage showing lymphocytes typically seen in pertussis. These are also ciliated columnar epithelial cells with numerous small bacilli where the arrows are pointing, adherent to the cilia. This morphology is typical and consistent with Bordetella pertussis. So now let's talk about diphtheria. This image shows a child with diphtheria showing the bull's neck appearance. You have seen this presentation before. Although diphtheria is an infection that is now rare in the United States, we think that it is still important that healthcare practitioners, especially infectious disease and microbiology practitioners, be knowledgeable of the clinical and laboratory features of this infectious disease agent. Diphtheria, as we know, is caused by the lysogenic strain or toxigenic producing strain of Corynebacterium diphtheriae, carrying the tox gene. The mode of transmission is by droplet spray. Incubation period is approximately 2 to 4 days, and the disease begins with fever, headache, chills, and nausea with vomiting. This shows the pseudomembrane at an early stage of clinical diphtheria. The toxin produced by the organism is synthesized in the local area, producing a lesion where necrotic tissue is accumulated, along with the fibrin, white blood cells, red blood cells, and bacteria, creating a membrane-looking structure called pseudomembrane. This is the hallmark of this infection. At the early stage of the disease, clinically, it is difficult to differentiate a streptococcal pharyngitis from the localized diphtheria. So it is not unusual that you may receive a request for both types of cultures if diphtheria is suspected. The toxin is also absorbed and carried to the heart muscle where it inhibits protein synthesis by inactivating EF2 that is necessary for protein synthesis. The pseudomembrane may also mechanically block the airway in the larynx and trachea. Cervical adenitis is present when the patient exhibits this bull's neck appearance because of the intense edema. It is important to consider diphtheria in the differential diagnosis of acute pharyngitis in children who may not have received their DPT or diphtheria pertussis tetanus vaccination. So this is one of the first respiratory tract infection that we'll talk about that is preventable through immunization. So now let's talk about this case study. A 4-year-old boy who recently immigrated with his family from Mexico had not received his routine childhood vaccinations, was brought to the emergency department with a history of 6-hour fever and difficulty of swallowing. He also had difficulty breathing. On visual examination of his epiglottis, upon assurance of airway protection, it was noted to be red and edematous. Acute epiglottitis, a life-threatening disease caused by Haemophilus influenzae type B or group B, produces a rapid onset and occurs primarily in young children between 3 to 7 years of age, or here between 2 to 6 years of age. The epiglottis becomes swollen that can mechanically obstruct the airway, which is fatal. The organisms somehow become invasive, spreading to the posterior pharynx, producing marked inflammation, progressive edema of the epiglottis, causing mechanical obstruction of the flow of air. The onset is abrupt, with sore throat and fever, drooling, respiratory distress with stridor, dysphagia, and dyspnea, that is difficulty in breathing. Because there is a concurrent sepsis present, blood cultures must be obtained. Rapid diagnostic procedures, such as direct antigen testing, if available, of secretions and body fluids may be appropriate. Treatment included adequate airway and antimicrobials. So let's do a case check. Epiglottitis, especially in children, can be a life-threatening emergency due to the risk of airway compromise. Any attempts, therefore, to visualize or culture the supraglottic region should only be performed in a controlled setting where airway protection can be assured. Historically, Haemophilus influenzae type B or HIB was responsible for the majority of the cases. As mentioned previously, the rates of infection with this particular organism have drastically decreased after the introduction of childhood vaccination for HIB, but cases still occur, especially in unimmunized populations. So let's end this presentation with agents of other upper respiratory syndromes. Rhinoviruses account for most of the common colds, especially in adults. In young children, RSV, parainfluenza viruses, and certain adenoviruses are responsible. Transmission is person to person and requires close contact and involves transfer of viruses from the hands of an infected person to the hands of the susceptible person. So hand washing is really important, especially in winter months. Acute rhinitis is self-limited, and usually the patient is afebrile. This is how you can differentiate or tell clinically a rhinovirus or a common cold versus an acute bacterial pharyngitis, for example, where in common colds, the patient does not have any fever. The syndrome is characterized by the production of nasal drainage, runny nose, sneezing, coughing, perhaps some malaise, and mild headache. What about other types of infections? Vincent's angina is caused by synergistic organisms, the spirochete Borrelia vincenti, and Fusobacterium necrophorum, or other Fusobacteria. Vincent's angina is an acute necrotizing ulcerative gingivitis, also known as trench mouth, that may extend to the pharynx and tonsils. Predisposing factors include poor oral hygiene, malnutrition, fatigue, emotional or physical stress. This is well recognized among World War I soldiers. The term trench disease actually was derived. When soldiers did not brush their teeth for a long time, they developed this disease or this infection, characterized by bad breath and foul taste. Now, thrush of the mouth. This is what you're seeing here, thrush in this person's tongue. Thrush of the mouth and esophagus is usually caused by Candida albicans, white, creamy, curd-like patches on the tongue, and other oral surfaces usually characterize this condition. Antimicrobials, chemotherapeutic agents, radiation, smoking, cessation of heavy smoking may lead to thrush. This concludes part 1.